everyone, welcome back to the Molar Bear. If you are a NEET MDS 2027 aspirant who finds general surgery a bit out of league, then you, my friend, are at the right place. Let us begin with an important topic, which is burns and skin grafting. So every year the NEET MDS exam has approximately 14 questions on general surgery, of which there are two major topics. First one is based upon the fluid calculations in burns and skin grafting, and another one most commonly it is based either on the thyroid gland or from the topic shock. So without wasting even a minute, let us begin. Basics first. सबसे पहले we are going to study about the layers that the human skin has. Okay, so as you can see in the diagram here, the uppermost layer of the skin, this is known as the epidermis. Epidermis is the topmost superficial layer of the epithelium of the skin. This epithelium is thrown into numerous enfoldings, which is known as retipegs. Below the epidermis lies another layer known as dermis. Now this dermis is divided into two parts, which is papillary dermis and reticular dermis. Now, papillary dermis is the upper part where the retipegs are present. So, for example, if this is the epidermis, this portion is the papillary dermis, and the portion of the dermis that does not contain the enfoldings or the retipegs, it is known as the reticular dermis. Now, why this dermis is very important when we study about burns is for the fact that this dermis is the portion of the skin which contains the nerve endings, the sweat glands, again the hair follicles and all the skin appendages. Below the dermis lies the hypodermis, subcutaneous layer of fat followed by muscles or bones. Now, moving further, comes the degree of burns. Based upon which layer of the skin is involved and how deep the thermal energy has passed, the burns can be divided into three main types, that is first degree burns, second degree burns and third degree burns. Apart from that, there is also a fourth degree burn. Coming to the first degree burn, as the name suggests, only the first layer is involved. Okay, so only the epidermis is involved in this case, first degree burn. So first degree burns, as it is very superficial, it is not considered for fluid calculation. This is very important. Whenever we encounter a burns patient, an integral part of the management of the patient is administration of fluids, which we'll be dealing in the later part of this video. But the first degree burns, since they are superficial and they do not lead to any fluid loss, the area of first degree burns is not considered in the fluid calculations. First degree burns, it involves only the epidermis. The nerve endings are not exposed. Okay. There is no blister formation. Healing occurs without scar formation. Examples, sunburns and flash burns. Moving to the second degree burns. So second degree burns are again divided into two parts. Second degree involves the second layer, which is the dermis. Now dermis also contains two layers, that is papillary dermis and reticular dermis. So the second degree burns, they are divided into superficial second degree, which contains of the epidermis and the papillary part of the dermis, and deep second degree burns, which consists of epidermis, papillary dermis, and almost entire of the reticular dermis. This is also known as partial thickness burns. This term is important, and this is considered in the fluid administration. So, superficial second degree burns. As you remember, I told in the previous slide that dermis is the part of the skin that contains the nerve endings. So, during the superficial second degree burn, the nerve endings are exposed. This leads to pain. So, these burns are painful. There is blister formation. There is blanching. And since the nerves are exposed but they are still present, so the sensation here is intact. Healing occurs by the proliferation of epithelium cells and appendages without scarring. No scar is seen. Moving further. So the deep second degree burns. Deep second degree burns, it almost involves the entire thickness of dermis. So again it is painful because nerve endings are exposed. Blister formation occurs because of damage to blood vessels. Blanching is seen in some areas. Mottled appearance is seen. Now another thing is that pinprick sensation is lost. Nerve endings are there but mostly they are damaged. So pinprick sensation is lost. Healing occurs with scar formation. Next is the third degree burns, or also known as the S-char burns or full thickness burns. Now the entire thickness of the skin over here, it is burnt. So this is known as full thickness burns. There is no pain. Completely painless. Why? Because nerves are lost. Nerve endings totally damaged. So there is no sensation. There is no blister formation because vessels, they are completely damaged and disintegrated. There is formation of a burnt tissue known as S-char. This is again very important. S-char formation. So what is S-char? S-char is basically a dried layer of the superficial burnt surface. There is scarring and contracture. Contracture means the wound tends to shrink in size. This leads to scar formation and all the sensation is lost. Now, full thickness burns, these are treated by a procedure known as escherotomy. What happens is that the S-char is incised surgically without any local anesthesia. Why LA is not needed in this case? Because the nerve endings are completely damaged. The patient does not feel any pain or even a pinprick sensation. So no LA is necessary for this procedure known as escherotomy. This is essential to prevent the formation of gas gangrene in further cases. We'll be learning about escherotomy in detail further in the further slides. Moving forward comes the fourth degree burn. This is complete damage with loss of muscle and fat treated by amputation. So moving ahead with the types of burns, based upon the cause, the burns may be divided into firstly electrical burns. So electric burns, they may be of two types: high tension burns, which have been caused by a voltage of more than 1000 volts, and low tension, which is less than 1000 volts. Now it interferes with the normal conductor system of heart. So the heart, basically it runs upon an electric action potential generated by the SA node. So any fluctuation in the voltage can lead to the disruption of the rhythm or conduction of the heart. Now another thing to be kept in mind is that blood, nerves, these offer least resistance to the flow of current. Means the current has high affinity towards the blood vessels and the nerves and the lymphatics. On the other hand, skin offers high resistance to electrical current. So as a result, whenever the electric burns takes place, the damage on the inside of the body is much more and more evident as compared to the damage on the outer side of the body. Now, as we discussed, that the electrical burns, they interfere with the normal conduction of a heart, that causes cardiac arrhythmia, atrial fibrillation, tachycardia, ultimately leading to cardiogenic shock. Now, high tension wire, it can lead to blast injury and injured myocardium of the heart. Apart from that, also along with the blood vessels and nerves, muscles also offer decreased resistance. So when the muscle is damaged, then myoglobin is released, affects the kidney. Also, myoglobin is excreted in urine, and the excess of myoglobin and partially damaged muscle, it can act as a food for the bacteria and ultimately leading to gas gangrene formation. Gas gangrene is formed by Clostridium valencii. Okay. Now, to remove myoglobin from the urine, the treatment of choice is alkaline diuresis. Next, coming further, is the filigree burns. Filigree burns are caused due to lightning. बिजली गिरने से जो burns होते, this is filigree burns. Moving further, we have scalds that are caused by hot liquids. Flash, which is caused by gas. Radiation burns by radiotherapy, and chemical burns by acid or alkali. Now there are two things. Firstly, whenever there is a chemical burn, you have to ensure that if the burn is a solid chemical, do not wash it with water. You wash it with water, it dissolves, it produces a reactive molecule, the damage is increased. So chemical burns may avoid using water if the chemical is in a solid form. Now chemical burns, it is of two types, acid and alkali. So whenever the acid causes a burn, a layer of necrotic tissue is formed. This tissue is impervious. So the chemical cannot penetrate the deeper, healthier tissue. So as a result, it has less damaging effect. This is important. Alkali, on the other hand, no impervious layer is formed, so damage is very high. So if you are clear with the types of burns, let us move further to the sequelae of burns. Sequelae means whenever there is a burns injury, then what all is the effect on the body. The most common and the earliest sequelae of burn is hypoxia. Hypoxia means decreased oxygen. Another is airway difficulty. Now why this happens whenever there is burns? Most common form of burns is mostly thermal burns. So whenever, assume a patient is trapped in a building full of smoke and he develops burns on the body. Now there are two things. First of all, the airway will be blocked. How? Because of deposit of unburnt carbon particles. So there will be presence of carbon particle, cankerous sputum will be seen, and there will be obstruction of the airway due to smokes and fumes. Apart from that, there may be airway burns. The hot fumes, it can cause the burns in the airway, in the trachea, in the nose. Other than that, there will be hypoxia because there will be a lot of carbon dioxide emission. As a result, there will be difficulty in breathing and overall hypoxia. Next is hypovolemia. Most common cause of early death in burns. This is an important point in regards to NEET MDS examination. Hypovolemia is loss of bodily fluids. So whenever there is burns injury, there is a lot of loss of bodily fluids that need to be compensated by administration of fluids, that is crystalloids and colloids. If not so, then there can be early death of patient due to circulatory collapse because of lack of plasma and bodily fluids and electrolyte imbalance, which is the most common cause of early death in burns patient. Next is shock. Again, hypovolemia can lead to hypovolemic shock. Apart from that, there may be septic shock. Next is lung damage by hypoxia and other changes. Next is cardiac arrhythmia. As we discussed, presence of electricity, high voltage electricity, it can affect the conduction of the SA node and in turn causes cardiac arrhythmia and atrial fibrillation. Next is the kidney damage. Kidney damage, especially again in the case of electrical burn, there may be myoglobin formation, excessive load on kidney. Again, if there is shock, then there is decreased urinary output, again affects the kidney. And last but not the least, infections or sepsis. It is the most common cause of late death in patient of burns. It is again a PYQ. This is again a PYQ. So moving further, let us recapitulate again. Most common causes of death. This is very, very important for NEET. Very, very important. You cannot afford to skip this. Most common cause of death on the spot before bringing to the hospital, it is hypoxia or breathing difficulty. Most common cause of early death is due to hypovolemia, circulatory collapse, circulatory failure. Most common cause of late death in patient, that is 3 days after or more than 3 days. Then it is septic shock or infection, most commonly by gas gangrene or Pseudomonas aeruginosa infection. Most common cause of death in electric burns and hydrofluoric acid accidents. It is cardiogenic shock. Clear? Now let us move to another high yielding topic of this chapter. Now, whatever I teach from this point onwards, it is very, very important from the competitive point of view. So please pay attention and try to understand the concepts also. Comment notes to get these notes in the description link. I will attach it later. Coming on to calculation of Burns percent. First is the rule of palm. It is the most primitive, most basic rule. According to this rule, one surface of the palm is considered to be 1% of total burn surface area. Next is Wallace rule of 9. This is the most frequently used. Now there are two problems with it. First, it overestimates burn percentage, and second is that it is unfit for obese patient. Why? Because if the patient is obese, then the abdominal area, it will be more than what is given here. The area of the limbs, it will be less than what is given here. So what this rule of 9 says is that head and neck together, front and back, it accounts for 9%. Upper limbs is 9% each, matlab total it is 18. Now trunk, that is, see, trunk is divided into thorax, abdomen. Front is 9%, thorax 9%, abdomen. Back 9%, thorax 9%, abdomen. Then there is genitalia. Genitalia accounts for 1%. That is lower limbs, which is 18 per limb. Now this is very important because it was a PYQ that both the lower limbs and the genitalia of the patient was burned. So calculate the percent burns in this case. So the answer was 37%. This is again a question given in the dental pulse and it is a previous year question. So Wallace rule of 9 is another important part from where the MCQ may be asked. Moving further. Management of the patient of burns. How will you manage a patient with burns in the emergency department? First of all, whenever a patient reports to you in general surgery wards, the basic rule A, B, C, D, E and इसके ऊपर एक छोटू C. छोटू C stands for circulation, but it is not the usual circulation. छोटू C means if there is any major bleed that can lead to loss of life. For example, ruptured aorta, bleeding femoral artery, massive bleeding. So you have to control that massive bleed first. Then we move to the airway. How do you assess the airway? If the patient is able to speak, the airway is clear. Basic. So how do you manage the airway and what are the clinical changes that you need to see? Clinical features, voice change. If there is a change in voice, obstructed, squeaky, thinned out voice, it is characteristic of airway damage. There may be carbonaceous sputum, that is presence of carbon particles or smoke particles. Black colored sputum may be seen in burns patient. How is airway damaged? It is damaged by hot fumes and gases. Treatment includes early elective intubation, tracheostomy, nasogastric tube, whatever suits the patient and the clinical situation the best, we have to go for that. Next is breathing. How will you assess the breathing? Chest movements. You always need to notice how the patient's chest moves when he breathes. The chest movement should be bilaterally symmetrical and the breathing should take place without the use of accessory extrinsic or intrinsic muscles. So if there is abnormal protrusion of the chest or the chest is not moving symmetrically, then you may have to suspect pneumothorax, rib fracture and all. So you have to assist the patient with the breathing. Next is the most important aspect of management of the burns patient, which is circulation. As we discussed, the most common cause of early death in burns patient is hypovolemia. This hypovolemia, it needs to be corrected. How do you correct it? You administer fluids. Now, important question. This fluid is calculated by Parkland formula. Parkland formula is 4 ml into total burn surface area into weight of the patient in kg. It gives the IV fluid in ml. Now, two types of fluids are available. One is known as colloids and other is crystalloids. So what are colloids? Colloids are larger sized molecules. We have studied three things: solution, suspension and colloids. So colloids are larger sized molecules that remain in the intravascular space because of their large size. Now, why are they preferred? For volume expansion, they are given in hypovolumic shocks, severe burns, hemorrhages, and severe bleeding. So colloids include whole blood, fresh frozen plasma, albumin, HES. This is important example. HES, you have to remember this. Gelatin, dextrins. How much colloid is to be given? For every 1 ml, same amount of colloid is given. For example, so the ratio is 1:1. Jitna fluid loss hua hai, we have to give the same amount of colloids. Now, half-life of colloid, it is very long. It is in hours and days. Potential risks are because they are derived from other biological sources. There may be allergic reaction, clotting disorders and kidney failure. So this is what is to be kept in mind. This is important. This is important. Volume expansion is important. Moving to crystalloids. Crystalloids are small water-soluble molecules that are distributed rapidly across the extracellular compartments. Purpose is maintenance, especially in case of hypovolemia, electrolyte loss. This is very important. And again, they can act as a solute for the delivery of certain drugs. Now, these are the examples of these. Burns may be administered these three. These are very important. Dextrose is for pediatric patients. Normal saline, most commonly used. Ringer lactate, best fluid in case of burns. Best fluid for early management of burns patient. Ratio is 3:1. You have to give more crystalloid than the blood or fluid lost. Why? Because they leak from blood vessels into extracellular matrix. Now, half-life is very less again, but there is less risk of allergic reaction. So crystalloids are relatively safer. Now, how do you calculate how much of the fluid is to be given? Now, this is the most important slide of this entire lecture, जहां से नीट का क्वेश्चन आता है. So what the Parkland formula says, if suppose the Parkland formula, according to Parkland formula, you derive at the conclusion that 3200 ml, this is just an example, that 3200 ml fluid is to be given. Firstly, which fluid will you give? For first 12 hours, crystalloid only. For next 12, crystalloid plus colloid So what the Parkland formula says, if for example 30 to 100 ml is calculated by the Parkland formula, so for the first 8 hours you have to give half of the volume, which is 1600 ml, and for the next 16 hours you have to give the another 1600 ml. Now note, this is again very important. For partial thickness burns and for children, the Parkland formula is modified. So the 4 is replaced by 2 into surface area into body weight. And for children, it is 3 into surface area into body weight. For children, another very important thing is you have to give dextrose. So in case of children, you always have to give dextrose. Why? Because during burns, the brain needs glucose. Brain needs Now in case of an adult, there is excessive fat. Fat is broken down into glycogen, and this glycogen forms the glucose which goes to the brain. However, in children, fat is less, so glycogen cannot be formed, and this thing cannot happen in children. So to compensate and to avoid brain starvation, glucose is given during the first 8 hours. This is very much important. Now again, avoid colloid for 12 to 16 hours, and again this is very important, that Ringer lactate and NS can cause acidosis. Clear? Now let's move forward. How do you treat the burns wound locally, which is the burns dressing? So there are 3 things which you can apply on the dressing. Again, there are things like open dressing and closed dressing. We will not discuss that in so much detail because it is not important from your MDS point of view. Local treatment of burns. Firstly, silver sulfadiazine. Now, this is very much effective against the bacteria that are present on the burns wound, that is the Staph aureus and Pseudomonas, which are responsible for the septic shock causing the late death. But the side effect is that it causes leukopenia, black staining. Next is silver nitrate. It is painful to apply. And now the nitrate. So silver nitrate is NaNO3. This NO3 binds to Na plus in the body. So, and this one will go and bind to the chlorine. So this will lead to decreased Na plus in the body, hyponatremia, and also methemoglobin formation, which will lead to chocolate brown colored blood. Now mefenamic acid or mefenide acetate, it penetrates into the eschar. This is very important. However, it can cause metabolic acidosis. Now we talked about escherotomy, that is a black dead impervious layer forms over the burn wounds in cases of full thickness burns. So this is known as eschar. And how do you treat the eschars? By surgically incising it in order to prevent further complications like gas gangrene. How is the escherotomy done? You give a straight incision perpendicular to the Langer lines. This is important because see, if this is the, for example, if this is the mandible of the patient, okay, this is the face, this is the mandible, Langer lines run like this. So to prevent any scar formation, all the incisions that you are giving electively, they are given parallel to the Langer lines. However, escherotomy incisions are given perpendicular to the Langer lines. Moving further, let us briefly discuss about skin grafting. Skin grafting is as such not very important. Matlab, this basics of the grafting is not important. The types of graft is more important. Coming to what is graft. So graft is basically transfer of tissue from one place to another without its own blood supply or nerve supply. यहाँ से काटा, यहाँ जाके चिपका दिया. This is graft. Okay. And what is flap? Flap में you remove it from here with its own blood supply and you slide it into the adjacent area. यहाँ से तुमने निकाला और यहाँ पे तुमने चिपका दिया. It is attached to the parent tissue by the pedicle. So this is flap and this is graft. Graft may be of different types. Autograft, खुद से लिया खुद को चिपका दिया. Patient's own skin is transferred from one place to another. Then there is isograft. Isograft means identical twin से graft लिया है. Allograft means it is from the same species. For example, from the mother or father or any close relative. Next is xenograft. It is from different species. For example, pigs and kettles. Next is concordant. Xenograft is genetically close species. Discordant is genetically distinct species. Now, what are the indications for skin grafting in burns patient or otherwise? It is wide local excision. Means if there is, for example, a tumor, then we keep 5 to 1 centimeter of wide local excision margin based upon how aggressive the tumor is. So as a result, a defect is formed which is huge. So to compensate that, you go for skin grafting. Next is post-burn wounds with granulation tissue formation. Next is reconstructive surgeries. For example, after you remove the oral squamous cell carcinoma from the dorsum of the tongue needs to be reconstructed. So reconstructive surgeries may you use skin grafting. What is the contraindication? It is presence of active beta hemolytic streptococcal infection, because the graft will not survive. Next is bone without periosteum. If there is no periosteum, how will the graft derive its nutrition? So again, in this case, the graft will not survive. Moving further to the types of skin graft, broadly classified, the skin grafts on the thickness of how much of the skin is taken for grafting is divided into two parts. First is split thickness graft. Now what is split thickness graft? It is also known as Therish graft. The donor sites are most commonly the limbs, thigh, trunk and supraclavicular area. This is the instrument that is used to harvest the split thickness or Therish graft. This is known as Humby's knife. Now, when the graft is harvested, there is punctate bleeding seen on the donor side. This is the donor side. So, punctate bleeding, that is tiny red dots, will be seen on the donor side. Now, on placing the graft to the recipient side, जहाँ पे graft हमें लगाना था, वहाँ पे जब हम उसको लगा देते हैं, तो first 36 hours the graft survives by plasma mobilization. Then capillaries form in 4 to 7 days, lymphatics form on day 6, arteries on day 7. Now, how is the grafting done? Firstly, the graft is harvested from the donor side by Humby's knife. Then the graft undergoes a thing known as meshing. Meshing means you create tiny holes or punches in the graft. Why these are important? Because after creating the mesh, you can stretch the graft almost 3 times. Up to 9 times is the maximum. This much the graft can be stretched. So as a result, a small donor site can cover a large recipient site. So this is known as meshing. And also the formation of these mesh helps the plasma to penetrate better. And as a result, the survival of the graft is improved. Now, what are the features of this split thickness graft? It can be stretched by meshing. It is not aesthetic and has high contracture. It is not aesthetic because again, the full thickness is not taken. The skin appendages are missing in this graft, and the contracture, secondary contracture, is very high due to presence of these meshes. Next comes the full thickness graft or the wolf graft. The most common site is the postauricular area behind the ear. Now, whenever you harvest the full thickness graft, you always tend to harvest it from an area that is not visible, that is mostly not important in terms of aesthetic, because the site from where you harvest it mostly is left raw and denuded. But when a larger graft is harvested, you need to cover the donor area also with another split thickness graft. What is the merit? It is used in aesthetic areas because it has appendages. It has all appendages including hair follicles, glands, matches the color exactly, so it is aesthetic. Demerits is that it has high primary contracture and meshing cannot be done, so it is used only to cover smaller areas with high aesthetic significance. This is all about burns and skin grafting. Thanks for watching the Molar Bear. Please feel free to like, share, subscribe, and your comments do help in keeping us motivated to bring more content to you absolutely free of cost. So till then, goodbye. Enjoy learning.